Good evening. It is July 7, 6 p.m. This is MED210, 6NAX. And what is due this evening is, of course, your task 6, discussion 6, and lesson 6. And I got some, well, depends, good news, bad news. Depends on how you are. I had a meeting with some of the other anatomy and physiology professors, and we're changing around the curriculum, and also I'm just looking at some of the stuff that you guys send for tasks and discussions and lessons, and I think you guys did enough of that for the rest of the term. So you may be wondering, well, okay, then what grades am I going to get for week 7, week 8, week 9, and week 10? So for this week, um, um, we're going to have quizzes instead, because we got to start practicing what we're preaching. And I'm going to see if the other class, which grades would be better. I'm going to compare your week 1 through 6 grades versus with your week 7, 8, 9, 10 grades, because yeah, your tasks help you and your lessons help you a bit on how to study for things, but there's no real litmus test or how do you really know that you're really soaking in the information. So this evening, at the end of this lesson, we're going to have a quiz on week 6 items. And if everyone participates, I'll give you, like, if you do poorly, you do poorly. That's okay. All right. I'll give you a chance to, do some makeup work, either a task or a discussion to boost your grade up. But going forward, we're gonna only have quizzes and, of course, your final examination, so that we can prepare you a little bit better for your final exam. So again, what's due today? Task 6, discussion 6, lesson 6. After we do today's lecture, we're gonna break a little bit, and then I'm going to put I'm gonna put up a quiz, and I'm going to send it via chat, and then you guys will have several minutes to email me the answers. Okay, and we'll practice that format. And if you do poorly, that's okay, right? If you didn't study this week, that's okay. But going forward, you should start looking at the items, because next week, when you come in for lab, you'll be quizzed on week 7 items. Now, the quizzes could be anywhere from 5, 10, 15, 20 items. I'm not going to make it like 20 items. It's most likely 5 or 10, even though I have 20 item ones in the bank if we need them. Now, what's week 8 and week 9 going to look like? Week 8, week 9, and 10, we are on campus. And I will put everything that I'm saying here in word form in your announcements. Week 8, week 9, week 10 will be on the 4th floor, Health Lab 1, Alexandria campus. Try to wear scrubs and or lab coat if you have it. If you don't, just try to wear something that you don't mind getting, getting dirty. Like, we're not coming in for fashion, just so that, we can give you a disposable smock or an extra lab coat. And try not to bring too many personal items. Now, for the people who have stated that they can't come to your laboratory, well, you're going to have an extra assignment. I'll make you do one of the tasks or discussions or whatnot. But so next week, when you come in, we're going to have not only in the laboratory, we're also going to have like a practical examination. For example, when we go cut up the brain, I'll give you 30 minutes to study after we practice. And then I ask you guys to step out of the room one by one. You go in, and it'll be oral, either it'll be a station or in oral quiz format, where I go, hey, where's the medulla? Point at it. Hey, where's your cerebral cortex? Point at that. Hey, it'll be very, very simple, because I believe we got to get back to what we used to have pre-COVID, when we had classes every day. And right now, the official word for September or for after summer is that we're going to still be on this hybrid format. I am one of the professors that are against it, but the majority of people are, it's still a pandemic, and there's still a considerable health risk. So on the ground classes will be, or classes with laboratories will still be 7 weeks via Zoom and 3 weeks on campus. And for me, if it's a class that I teach, I always put it on the back end, week 8, week 9, week 10, so that there's more than enough time to make plans and to get a sitter and to make plans with your job and whatnot. But if there's no way out of it, then I need a call, and then we need to make other arrangements. But like I stated earlier, and during week 1, you paid for this. It's a laboratory class. You paid for the hands-on stuff, which is part and parcel of anatomy and physiology. So that's for week 8, week 9. And what's going to happen week 10? For those of you guys can make it, week 10, you show up to Health Lab 1, 4th floor, Alexandria campus, 6 p.m. on that particular Wednesday evening. And you follow the protocols on the board. And then you take the exam, and then you leave. I scan the results, send it back to you. Now, another thing that I also mentioned, when we go into laboratory, before you do anything, you lay what little personal items you have in a particular section in the back of the room, which I'm going to have set up for you guys. And then you do a clinical scrub in, you glove in. So all intents and purposes, you shouldn't be touching anything with your bare hands, and of course will be gloved up at all times. I mean, not gloved up and masked up at all times. Okay, and despite whether you're vaccinated or not. And by the way, majority of the nurse candidates, someone told me it was like 90-something%, and all clinical staff and health science, we are all fully vaccinated. Okay, so that's the public service announcement. Let's jump right in, because what are we looking at for this week, for this week's lecture? Special senses. Now, we already talked about the endocrine system and communication. Now, endocrine system is slow, but its effects are long-standing. Now, the thing about the nervous system and the special senses is that it's fast. And the special senses, of course, are smell, taste, vision, hearing, and equilibrium. Hearing and equilibrium, they go together. Smell and taste, they also go together. And it's in the chapter 14.1, sensory perception. So we're going to go over all of these mini anatomy sensory stuff, and for lack of a better term. And there's some really nice quick notes here in the step 3 of your task, special senses, and of course the lovely Carolina notes. And we can't do we used to do the lab, but we can't do it because of COVID, and we're doing tasting things. And so there's really nice quick notes and some pics, but I like the pics in your book better. So let's go over sensory perception, chapter 14. And before we do that, we have to see where in let's see. Let's go to the chapter first. Maybe they have it. So chapter 14, 15, 16, endocrine. No. Was it 13? Okay, nervous. Huh. Oh, was it? Am I crazy? What chapter was it? Am I that sleepy? Chapter 14:1. Okay. Sensory. 13 central nervous. 14 somatic. There you go. Okay. So let's look at, I think we got to look at, before we can get to this, let's look at its role. Now in homeostasis, and it's this picture, which is this lovely picture right here. You know what? Let me just take this. We could put it right here. And then so I can make this available to you as well. So when we look at homeostasis, which is pretty much your existence, this is what's happened to you every millisecond of your life. Homeo means the same, stasis means to stand in one place. So that's what your body does all day. And there must be some sort of stimulus which will provoke a change, and the change gets sensed by a receptor. Okay, so there's an organ, and these are the ascending tracts in your spinal cord, and your control center is always your brain. So this is your sensory pathway or your ascending pathway, okay, in your spinal cord. Now, your brain, of course, is the control center, okay? Your brain picks up whatever this sensor is assigned to pick up. Let's say, for example, I see headlights coming my way. Okay, I'm in the middle of the street. I see headlights, right? So my brain tells me, maybe I should move out of the way. And that's your descending pathway, which is your motor pathway. And your motor pathway is part of, also known as your effector pathway. So you have your sensory and you have your motor. And then the motor will tell you, hey, we have to affect the change or something bad's going to happen. So this happens to almost everything in your body. And what we'll be focusing on today is this, the sensors, the receptors. Now, here's the freaky thing about this whole lecture. And I believe we go over taste buds first, or gustatory sense. Everything that you are sensing right now, my voice, you see what's on the screen, it's not really what you're sensing. Your brain, everything that you're experiencing right now is essentially a machination of your brain, right? Like when you look at this, this is the color green. But when you think about it, how do I know it's the color green? It's because somebody in kindergarten told me what? This is green. I mean, it could be blue. I don't know. But I was taught and I was trained that if this, whatever this is green, and my brain will then, because your receptor only picks up modalities or changes of in energy. And then it sends those changes via an electrical pathway and a chemical pathway, which is your nerves, ascending tract to your brain. Your brain then interprets it, and then your body moves to react towards it, if necessary. And in order for the overall function of your body is to keep the balance, keep the homeostasis, okay? So that's, when this was first lectured to me in, I don't know, first year biology or first year, I took invertebrate anatomy, I think, second year in undergraduate. And I thought I started, it's a pretty much of a mind trip, isn't it? When you think that look around this room, how do you know that's a chair? How do you know that's a ceiling? How do you know that's really what you're sensing? You don't really. Your brain tells you that's what it is. How how do you know that your voice sounds so awesome? Have you ever you sing in the shower and then someone records you and then you listen to your voice in real time, and or in you listen to your voice in a recording, and you say to yourself, oh my gosh, that's not my voice, that's an awful voice, that's not my silky smooth voice, I should have a record deal. But who's telling you that's what your voice sounds like? It's your brain. Okay. It goes, and now you could see its implications in mental illness. Anyone here ever had a hallucination? Anybody? And could you tell me, what was that hallucination? Did you see something? Did you hear something? Anyone having have a hallucination? And I'm not talking about like I was drinking a lot and then, I started seeing a leprechaun, or I was doing some shrooms and then, I met Jesus Christ. None of that. But like maybe you were just sitting there and you heard or saw something or felt something that wasn't there. Yes. Anybody?
I haven't.
You haven't?
I had a hallucination on Tamiflu.
Oh yeah, well that's because I gave you a drug, right?
Yeah.
And it's because of the chemistry of my brain, and then my brain's gonna start doing. But how many of you here are parents, and then you've been separated from your kid, maybe because of work or circumstance? You ever hear their voice?
I do.
Yeah.
I have.
Yeah, I have. Yeah, I heard that.
You're like, oh, sweet Jesus! Like I'm the only one downstairs. Like, why do I hear my babies? I don't want to hear my babies, but I hear them. Or has anyone, oh, you can't tell me no one has hallucinated, like maybe you were studying too long. Have you ever felt that there was somebody in the room? Like you saw like a shadow move to your side, or you felt someone touch you, like touch your leg? It happens to me like at least every other day, but no, there's nothing there. What? Because now you could see pathology, right? When the control center starts like misinterpreting sensory, right? And then you do what? You guys have an effector, right? You can cry, you can run, you kind of freak out a little bit. It happens, right? So now you can know why, know exactly. And I know that's a very, very wild and freaky thing to say, that everything you see and hear isn't quite real. Your brain makes it real. So that's a little trippy, isn't it? Especially if you have mental disease or mental defect, right? Because then it will start affecting what? The things you do. And that's kind of dangerous. That's why I always state that if you're dealing with a psychopathic patient, psycho meaning mind, pathy meaning disease, be very, very careful, right? Do you know how they say that people with mental disease or defect are stronger than normal human beings? It's not true. But if a human being has no brain to tell them, or no ego, or no ethics to tell them, hey, stop, how dangerous would that person be? A classic example is my nephew, CJ. He is profoundly autistic, and he's very low on the spectrum. He doesn't speak. He's a good, 280, 6'1". When he throws a tantrum and sees me as a threat, what do you think he's going to do to me physically? One time I took his Doritos away from him. He's also a fellow Dorito addict. And last Christmas, I took his Doritos away from him. He tackled me. We got into a wrestling match, and he crushed my glasses onto my eyes and my face. Now, does he have superhuman strength? No. But you could see how the chart that I showed you, his brain detected what? Sensory, a threat. And then what did he do in turn? He started fighting me, and he started trying to hurt me because I was threatening his enjoyment and his things, just like as a child would. And the problem is, when a 2-year-old throws a tantrum, it's one thing. When a 18-year-old, 200 plus pound child throws a tantrum, that's something totally different. How many times he's given a black eye to his father? he pushed his mother down a flight of stairs. Didn't mean it, right? But again, the processing, and for your autistic patient, the processing of sensory is very, very exaggerated and very, very much distorted. And that makes them very difficult to communicate, makes them also difficult for compliance and telling them like, and telling also these patients what to do. So knowing that, you can now understand how delicate psychology and psychiatry is. And also how delicate pharmacology is, because those of us who had a couple of drinks before, anybody here, like, well, let's not get into that. But you guys ever heard of like beer goggles? You know, you have a couple of drinks, right? And then you see the most beautiful person in the world. And then the next day, they're like, hey, Nelson, why are you kissing those two dudes? And I'm like, I don't know. And it goes, she was beautiful. It wasn't a she, it was a he. And he goes, and then guess what? I looked at my jacket. It was the dude's number. And I was like, I was freaking out, right? Because I'm a heterosexual male. But what made me act differently, right? The sensory input was now skewed. So the judgment is now skewed as well. And what will happen to the motor? The motor response will be very different. So think about that pathway when we're talking about sensories. And all a sensor does is transduction. It takes energy and then changes it to a something that the brain can read. And what can the brain read? The brain reads electricity and also and some chemicals as well, but typically electricity. And that electricity is called an action potential. So this is a typical nerve cell, and you have dendrites here, and you have an axon, and this is myelin, this light blue stuff here, and then they connect to each other. Now, the electricity hops from one node, if you see here, this yellow, and that's called saltatory conduction, and it makes it very, very fast. So for example, on one end, here's a classic example, you have a photoreceptor, and here's a rod, and we're going to talk about rods and cones. A rod is a receptor in your retina that picks up your night vision and visual acuity. You guys notice you don't see really colors at night very well? And then you have cones for that, for the daytime vision. But all your eye does is just pick up light. And then it transduces or changes that light energy into electricity. And then the electricity will go up to the brain and then be interpreted. That's why maybe if you guys, well, we're going to be talking about blind spots and things of that matter. That's why there's an actual blind spot in your field of vision, but your other eye sees that what's in the blind spot, and then your brain fills in the blanks. And that's why I used to be in a school that had, what do you call that? It had a criminal justice program. And I used to always love going to their laboratories. So, you know, learn how to frisk, you know, perps and do observations and thing. And one of the favorite exercises that me and the professors love to do is we used to have like fake bank robberies and fake muggings. And I used to come in and play the bank robber, and then there would be 1,000,002 different descriptions of who was the perpetrator. If you had 5 students in the room, there'll be 5 totally different or slightly dissimilar descriptions of what they saw, because your vision is highly subjective. It's based upon the interpretation goes of the events of your brain. Now, that's also very important to us medical professionals, because we use our eyes, ears, and all of our senses all day. And things could be very much interpreted. Like today, I forgot if it was this class. Somebody called me like, Dr. Garais, are you mad at me? And I said, no, why would I be mad at you? But you know, when you read emails and when you read a text, depending on how you look at it, do you guys notice that you could be insulted or you could be um, um, uh, or garner some pleasure off of words? For example, like, what are you doing? Right? What are you doing could be like, what do you mean? What am I doing? Are you asking me out on a date, or are you interested in me? Or what are you doing? Like, what? You don't think I know what I'm doing? Do you see how it can be totally misinterpreted because the brain has to take that data and then quantify it. But the receptors is raw data, okay? And transduction converts that raw data into an action potential, into something that the brain can semi-understand. And then the brain will then make some sense out of it and then send a message to your effector or your descending tracts to go do something about it. Here are other types of receptors. We have chemoreceptors that can, are the most common chemoreceptors are the ones that pick up oxygen and carbon dioxide and hydrogen ion for your pH. We'll be talking about chemoreceptors when we're talking about taste and smell. Osmoreceptors respond to concentration of body fluids. How much salt do you have? How little salt do you have? Nociceptors are special, also known as delta fibers. They respond to pain. You could also have mechanoreceptors, okay? Your position and balance through your body. Thermoreceptors, that's how you know if something's hot or cold. So even hot or cold, it's highly subjective. How many of you have like grandparents, like when my father-in-law is here in the house, it would be like he sets the thermostat to like 65 degrees and he goes, and he's wearing a sweater. It's so hot in here. I'm like, geez, we're all freezing to death. And also babies, my younger children, everything to them, they can handle any temperature. You ever see kids play outside in 10-degree weather without a jacket? But you don't see that in most adults. Again, highly subjective. You could also have the visceral sense. What's in your gut? You know, when you ate something bad and it's part and parcel of your autonomic nervous system, that's how you kind of know you're about to throw up. It's also how you know you have dyspepsia. Okay. We'll be talking about the special senses because there are sensory organs that are specific and hold a specific function. And the first one is, of course, your gustatory. Okay. Now, if you look at your tongue, and we're going to look at if you had anatomy and physiology 1, if you recall when we took out the tongue, there's variable textures. This looks different than this, looks different than this, looks different than this. And it's because there are actually different types of cells in different sections. But all of them have hair cells. And these hair cells are chemoreceptors. And these chemoreceptors have to be in some sort of aqueous solution, hence another reason why we have saliva, hence why you should, when you eat, you should drink some fluid or drink some water. It's like, have you ever eaten just a whole bunch of crackers? When I was a kid, I used to be like addicted to Nilla wafers. That was pre-Dorito days, before I had the Dorito goodness. You do eat enough of them, it doesn't taste like anything anymore, especially if you don't drink water on it, because taste buds require, or hair cells here, they require an aqueous environment. And by the way, you also have hair cells in your nose as well. And they're called hair cells, but they're not really hairs, but they're little finger-like projections that come out of here. And then they'll take that chemistry, whatever it tastes, and then send it as a signal. So that too is also part of your culture. When I was stationed in wasn't New Mexico, San Jose. I was stationed in San Jose that has a quite large and diverse Mexican American population. A lot of the people who grew up there eating, the ultra spicy green mole, I couldn't handle it. I thought I could handle it. I can't handle it. I was choking, and I was watching 5-year-olds eat it like it was what? Like it was ice cream. And it's because why? They are accustomed to it. Their hair cells know how to read that chemistry, and to them it's pleasurable. But to me, it was just all sorts of pain. Another cool thing about, because it was different textures and different kinds of papilla that are connected to these hair cells, it forms regions. And I'm not quite sure if there's a nice picture in your textbook, but this is just a better thing to look at. If you look at this, the sweet and salty are more typically towards the tip, sour is on the sides, and bitter is most part of the more posterior part of your tongue. Okay, and the term umami, which you see in this one here, it just means like delicious tasting, or a delicious taste, or something like that. And the students and the professors on the 5th floor Alexandria campus, which is baking, pastry, and culinary, they understand the chemical relationship with all of these. Like here's a classic example. Have you ever tasted baker's chocolate, right? It's like pure sweetness. That's why it tastes like garbage. But it isn't until you add the salt and add other materials that makes the chocolate taste good. And it is usually a balance of these different things that make things taste good. And another thing that makes things taste good is, let's see if they have it here in your textbook. Here you go. Dissolved glucose. There are taste buds that are directly linked to sugar, and those are called glucostats. And glucostats, you know how they say that, oh, you have a sweet tooth, right? And that's part of the gustatory cells that make people enamored to sweets and sugar. And also, we also know what low-fat versions of our favorite foods taste like. Can we all be honest here? It tastes like garbage. The baked Doritos and all these products, these baked Cheetos and baked, whoever invented all those was baked, okay? Because what's it missing? It's missing that fat. There's so much fat in Doritos. Anyone here go camping and want to start a fire? You don't need to bring any like fire starter. Just bring a bag of Doritos and light a Dorito on fire with some kindling. You got yourself a fire. That's how much fat is in there. And that's the reason why that Dorito tastes really good and much better than your baked goods version of it. It's because of your lipostat. Lipo is, of course, fat. And I remember Chef Nori, every time she gives a demo and then she adds heavy cream or she adds duck fat to something, everyone's mouth starts watering, and the smells, right? Because remember, your gustatory sense, which is receptors of hair cells, the receptors on your sense of smell are the same kind of hair cells. Your nose also requires an aqueous environment. Yes? In order for you to smell things. Anyone ever been in a desert for a while? I was in the Sudan in the 80s with a lovely group of gentlemen called the United States Marine Corps. And I was standing on a pile of dung and I didn't even know it because the air was so arid and was so dry that there was no fumes, because fumes require some liquid in the air. So if it's super dry, just like your taste buds, it's very, very hard to sense. That's why when we went to jungle training in Okinawa, oh, you could smell everything. That's actually the exact opposite problem. At the jungle warfare school in Okinawa, you smell everything. My goodness, you could smell everything. But when we were in the Sudan, I could smell nothing. I don't smell a thing. And smell is olfaction. The sensory, right, is a hair cell. And if you look here, the hair cells, they're located here in the inferior part of your skull in an area called your cribriform plate. So this is your ethmoid bone of your skull, and this is your cribriform plate, which forms the holes. And what's in there? The same kinds of cells that they would have for, you see this little olfactory cilia, those little fingers, just like hair cells. There you go. And those hair cells would then, in an aqueous environment, pick up certain chemicals, and then it would transfer and then bring it to your brain. And again, like why do people think that one smell is better than another smell? Especially those of you who are parents, right? Kids are gross. They smell awful, right? But to me, it smell like my own kids. They don't bother me. So if my patient has anosmia, then I'm most likely thinking a potential neurologic, especially if there's any blunt force trauma to your face. Your hearing. I don't like this. Let's get a better picture. I like this picture. This picture's pretty. I like pretty things. Don't we all? Okay. The ear is broken up into three parts: outer, middle, inner. Now, the outer part, not too much to talk about. The only thing you really know about is this whole thing here is also known as your pinna, P-I-N-N-A. This out here is a vestigial organ, meaning it serves no real purpose in the real life other than to hold up your glasses. How do we know? People who are damaged to hear. Welcome. Right? Those of you who are parents love to hear your baby's voice. I don't, not anymore. Pinna, right? It doesn't collect sound. What collects sound is your ear canal, also known as your external acoustic meatus. Okay, the opening here. And we know that from anyone who has any severe frostbite or burns, then they lose their ear. There is only a nominal hearing loss. Now, the transduction in hearing is very special because sound waves, which is the energy that it's going to get picked up, travel through here, your external acoustic meatus. Then it hits your eardrum, which is your tympanic membrane. That sound wave is going to then be converted to mechanical energy. Now, when you put your hand right next to your mouth when you talk, me, hello, 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 you can even feel the vibration. So your tympanic membrane starts vibrating. Then it will vibrate these three smallest bones in your body, which is your malleus, incus, and stapes, which are your ossicles, ossicles. So if anything happens to this, anything happens to these bones, you're going to have a hearing problem. So your malleus, incus, and stapes, those are your ossicles. Then this part here is called your oval window. Once it hits your oval window, there's fluid inside this cochlea. Let's look at the cochlea even closer. Maybe in our textbook we have a better picture of the cochlea. There you go. Now, inside your cochlea, there are all these passageways. And just like there's also fluid in there. So that sound or that vibe got turned into vibration. The vibration now vibrates in this thing. There's fluid in here. And then guess what happens? It hits this thing called organ of Corti, which has hair cells. And depending on how the hair cells vibrate, it sends a message to your cranial nerve 8, also known as your vestibulocochlear nerve. But it hits the cochlear branch, or this shell-like thing, which is your cochlea, right? And that's your cranial nerve 8. And then it sends signals to your brain in the form of action potential that your brain can understand. That's why, have you ever seen those silly memes on TikTok or whatever, where they, where maybe the crowd is chanting one thing, but you can hear 6 different sentences by the same chant? There's one where it's some football club in Great Britain, and they're chanting, and what's printed on the screen are like 8 different versions of what is potentially said. Because again, back to the interpretation of the brain of the vibrations that were here and that went in here, right? And again, back to what we were talking about, especially in hallucinations. Maybe you heard it wrong. Or how many times have you ever heard, like, maybe you were in a bad mood. Have you ever heard somebody like say the simplest thing, but you could have sworn there was a tone, like, she said the right thing, or he said the right thing, but that tone, it's ticking me off. Or especially if you have your crush. When I was younger, how many times, you know, my crush would say something to me like, hey, do you have a pen? And I'd say to my friends, oh my God, did you hear her? Did you see how she said, hey, do you have a pen? Like, she's talking about my pen. Maybe she wants me instead of my pen and my pen. You got anyone here? Or I'm the only loser in the room, right? Like, never did that, misinterpret it, or misinterpret something, right? Because why? All the thing that's going through this nerve is just what? Electricity that's measuring how many times these hair cells moved around. That's it. So again, that's why we as medical professionals, we always ask twice when we're taking a history, just to make sure that's what I heard. Where was I? So that's the organ of Corti, and it has hair cells inside. This is your vestibulocochlear nerve, and it has 2 functions, but the first function we're going to talk about is hearing. Okay, so let's go back to the big picture. So you could see if you have cerumen or earwax or ear butter, whatever you grew up with slang you called it, you can imagine if there's stuff in here, how it's going to block those sound waves from physically hitting your tympanic membrane, and it's going to sound muffled. Or if there's a bug in there, or all sorts of things could mess it up. Or if I maybe have some pus or some damage here, how it's going to be a problem. It also could be a nerve problem that can mess up my hearing. Now, your middle ear is highly pressurized, and it's connected, your middle and inner ear are connected to your throat via your eustachian tube. Now your eustachian tube, potato. This is the thing that pops, when you go on an elevator in a high rise, or if you're on a plane, because these pressures have to be equalized, or if maybe you go swimming, and that's actually how you hear. So it's quite a very amazing thing, the transduction of sound waves. And also, don't you think music is highly subjective? Think about it. Like, you think your song is like the best song in the whole world, and everyone was like, oh my God, that's so corny. It's awful, that song. Or you think like, oh, again, back to my own singing. Oh my God, that I should have a record contract. I really should. But then you hear it on a tape recording, and you're like, oh my God, the mic has to be off. It's got to be something different. Because my son is into A&R or audio and recording, and he wants to be a rapper or some ungodly, stupid thing. But it all relies on what? The subjective hearing, which turns sound waves into mechanical energy, into more mechanical energy that goes through here, through this fluid, and into electrical energy into your cranial nerve 8, your vestibulocochlear nerve, and the cochlear part of the nerve is the hearing portion of your nerve. Now, we already know that a lot of hearing problems, like if you have some hearing problems, or if there's water in here, or if you get an infection, maybe some of you had otitis media, especially if you got kids. Starts off with a sore throat, and the next thing you know, you got an earache, maybe some fluid comes out of here. Or if some of you, like me, I'm a former swimmer. You can't tell it by now, I'm more like a puffer fish, but at one time I was actual swim for real. What do you call that? I used to get infections all the time because most public swimming pools are not the cleanest thing in the world, and water gets trapped in here, and then it causes problems, and then I would have some hearing problems. Same thing also. You guys may have known that I've been in the music industry for more than 30 years as a DJ. So my left ear has now like 30% hearing loss, because just imagine, for the last, I don't know, 30, 32 years, I've been putting speakers and headphones in my left ear, and it plays, and clubs are really, really loud. And if this gets abused, the hearing potential will get less and less and less. So that's hearing. Now, if you got a hearing problem, you also might have a balance problem. And here are your semicircular canals. They too have fluid in it and hair cells. Now, if you look at these semicircular canals, they are organized in a certain way. And let's look at, I think there's a nice picture in and here's a better picture of the cilia, or these little hair cells that move around, right? It's a lovely picture of the organ of Corti in your cochlea. Okay, what's going on? Why is it making it bigger? Okay. Okay. Let's look at this. Do you see how in your semicircular canals, one is going this way, flat. The other one is going another dimension, up and down. And another one is going like diagonal. So they have fluid in it. And fluid will go wherever gravity, where the gravity ends up. So when you tilt your head to the left, and I'm tilting my head to the left, and you could do this at home as well, even when you close your eyes, you kind of know that you're tilted to the left. And when you right yourself up, you kind of know that you're right side up, because then the water then moves and then sends a signal. And if you move your head to the right, the water moves and then sends a signal. And again, do you see this? You have these hair cells, and there's endolymph, there's fluid in here. So if the fluid sloshes around and moves it, it moves these hair cells, and then what happens? it sends a signal to your vestibulocochlear division of your cranial nerve 8, vestibulocochlear nerve, and then it tells you what? Oh, this is the position of your head. But those of us who maybe have maybe had a couple drinks too many, yes, am I the only one? Right? If you had a couple of drinks too many, you guys know what? Hard to tell what side's up. Or maybe you woke up like maybe hungover and the whole room is spinning just because you looked over at your roommate or whatever, right? And then the whole room would spin because why? You just moved your liquid around, but the signal is all what? Messed up because alcohol is a potent drug and it'll do a number on you. And so the vestibular portion, and these are your semicircular canals, the vestibular portion helps you with balance and equilibrium and knowing where your position is. Okay. And here's a little bit better picture. So that's why when you spin your, you ever play that game where you spin round and round and round and round, like on a broom handle or a bat, and then you try to, you like go into a sack race or something. I don't know. I don't know what you all do on the weekend, but if you recall that that game when we were kids, or anyone who has children, or maybe you were an odd child like my eldest. He's not my eldest, my number 2. He used to, him and my boys, actually, all 3 of my boys, when they were all babies, they loved to spin around in a circle, and they get dizzy. And like, look, Papa, I'm drunk, right? Until one day Duke fell down a whole flight of stairs and then cracked his head open. And it's because of why? The fluid goes round and round and round. It's not, fluid doesn't stop on a dime. It's going to slosh around a little bit. And then what's going to happen? You're going to get dizzy. Now, what happens in things like vertigo and things like maybe side effects of certain medications and things of that matter, right? You could also get dizzy. Sensation, touch, okay? We kind of talked about that in when we talked about your the skin. So I'm not gonna go over that too much. Just know that the 2 main ones that they always talk about is Meissner's and Pacinian. Your Pacinian corpuscles they're located in your deep dermis, and they are responsible for deep pressure sense. And Meissner's is in your upper part of your dermis, and that's light touch. They always talk about these 2. These 2 are most common. Let's look at vision. Okay, good. So now I know. So what is the function of your eye? The function of your eye is to take in light. And the sensor is called your retina. And your retina then sends the signal to your brain. And your brain interprets what you see. That's why I said it's kind of a freaky thing to know and understand that everything you see isn't really real. It's really actually a machination of your brain. Every time I'm in traffic, I always question my reality. I start looking at my fingers. I start looking around. I don't know. I was a strange child and now I'm an adult. I'm now a strange adult. So that there are parts of your eye that has to be clear so that the light rays can go through here. So there's a clear covering for protection, and that's your cornea. And of course, eyelashes will also protect you. And you have a certain, you got these muscles here. Your superior rectus, inferior rectus, medial rectus, lateral rectus, and rectus means straight. And they pull your eye towards the area that they go. So superior rectus will pull your eye up. Inferior rectus pulls your eye down. Your lateral rectus will pull your eye to the side, and your medial rectus will pull your eye towards your midline or your nose. And your eyes, cranial nerve 3, 4, and 6 connect all of these, and your eyes move together. And they move together because I mentioned earlier, you have a blind spot, and I'll show you where you get that blind spot. So you have a sclera and a cornea, and they're protective, and the cornea has to be clear. You also have vascular tissue that's in there, and the choroid is part of it. And you also have the opening, which is called the pupil. Now, when you look at the eye, the way the eye kind of bends light, it'll bend the light so that the light will end up in this back part here, which is called your retina. And your retina has those rods and cone rod and cone sensors that we talked about earlier. So the function of your eye is to bend the light so it ends up back here somewhere. So your pupil has to be open, your cornea has to be clear, this lens has to be clear. This front part of your eye is called your anterior cavity, and that has your aqueous humor. Humor in medicine is an old Latin term meaning fluid. So the fluid here in the front part of your eye is water-like. The fluid here in the back part of your eye, in your vitreous chamber, and that will be your vitreous humor, that is gel-like or jelly-like. And why the difference of the different kinds of fluid in here? It's so that the light will bend. So when the light rays, they come in all disorganized. It comes in right here through the pupil, then it comes here, it bends, and then bends again. And if your eyeball has a good shape, right, it should end up on your retina, in theory. Right? Now, you also have your ciliary body, which contains your ciliary muscle. Now, and the suspensory ligaments, which takes this lens and moves it around. And if you guys recall, again, another weird kid story, anybody here ever like take a magnifying glass and light some ants on fire, or maybe light some leaves on fire? No, I'm the only one. Well, you'll notice if you do that, you bend, you like kind of turn the magnifying glass a little bit, and it focuses the light into a wide beam, into a narrow beam. And that different kind of focusing is refraction, or the bending of light. The bending of light or refraction is very, very evident. You know, when you stick your hand inside a fish tank to try to get your fish to clean it, right? Your hand looks weird and looks different because you're looking at your hand 1 minute in the media of air, right? And then you're looking at your hand through water, which is very, very different. And the light will bend and it will distort it. And that's why if your eye shape is off, if the clarity of your cornea, your lens, or the aqueous or the vitreous humor is off, you're gonna have poor vision. And that's why you have glasses to change the refraction of light so that the light can end up in the retina where it belongs. Now, your retina is connected to your cranial nerve 2, which is your optic nerve. Goes directly into your brain. And remember, both of your eyes are connected because of something called the blind spot. Here is your optic disc. There's going to be a point, a circle, in the back part of your eye that won't have any retina. Think of your retina as a bunch of cameras, and that's the rods and cones, the sensors. The rods are for night vision and visual acuity, and your cones are for color vision or day vision. And this optic disc or blind spot, it's this one part of your vision that doesn't have any cameras because you have to have your artery and veins go through here, and all the wiring for all these cameras called your retina have to go through here into your optic nerve as well. So there's going to be a blind spot, but you'll notice that your other eye will see what your blind spot doesn't, and your brain should fill in the blanks. Okay. And it also, seeing from two different perspectives, also helps you in depth of field, meaning you could see depth, like you could see how far away something is and or how close something is. And you could look on like YouTube. There's these like little cute little things. How do you know you have a blind spot? There's these little cute little things like this.
You can help change the future of medicine and receive over $450 while doing so.
Gee, a whole $450?
Okay, in this video what I want to do is show you how to find your blind spot. As light comes into your eye, it hits the back of your eye where your retina is, and this is where your light receptive cells are. Now most of the information that you're going to pay attention to is going to be in the central part of your vision right here in the fovea region. This is where all of your color sensitive cells are, and this is where you mostly pay attention. So when you look at something, you're mostly pay attention in this area here, and the other parts of the retina are your peripheral vision, but you can still pay attention to them, and if you do that you can see this. You have a blind spot where your optic nerve, which carries information out of the eye and into your brain, meets with the retina. There's this fairly significantly large region where you don't gather any information, and what I want to try to show you in this video is how you can observe the fact that you do in fact have a blind spot that you probably are unaware of. So here's what we're going to do. We're going to arrange it so that this O is in your blind spot and it will disappear, and all you'll see is a white background. Now in order to do that, what I need you to do is to take your nose right now and position it over this X. So move your nose over the X. Now close your right eye, and with your right eye closed and your nose over the X, start moving towards the X. Slowly move forward, and as you approach your computer screen, you'll notice that at a certain point you'll see the X, but you will not see the O anymore. And if you move your head back away, the O reappears, and if you keep moving your face forward, the O will reappear. But
All right, how many of you tried it? Did it work for you guys? Work for me, even with my glasses on. Look at, put your nose pointing to the X. Cover your right eye, and then move your head slowly closer to the screen. You'll see that the O here disappear, and that's your blind spot. And that's like one of these little cute little things that they have online. So, and also I forgot to mention the fovea centralis. That's the majority spot where you want the majority of the light rays to hit. And that's why your eye is designed that way. But if you have like astigmatism where I have it in my left eye where this isn't quite round and more egg-like, that's a problem. If you have like cataracts, or you have diabetic problems like diabetic retinopathy, or corneal abrasion secondary to diabetic issues, you can easily go blind. Oh, by the way, diagnose diabetes mellitus. If unchecked, within 5 years, your patient will become legally blind. And it's almost like a clock. So know the parts, know why we got a blind spot, know rods and cones, fovea centralis, and we have rods and cones here. Remember, the cones are for daytime vision and color, hence cones, color, and the rods are for nighttime and visual acuity. And you can see how they're directly connected to nerves. And then all the nerves get confluence together and become the cranial nerve 2, which is your optic nerve. And you should be, and this is the visual spectrum, Roy G. Biv, red, orange, yellow, green, blue, indigo, violet. My daughter says this is the new one, but I don't know. This is what I learned in grade school. That's why you have infrared, can't see it. Ultraviolet, can't see it. But within this spectrum, you should be able to see it. And just like a computer screen, the primary colors are red, blue, and green, RBG, right? And then all of them together can make a multitude of colors. Let's see. No. What's going on? Sensory, spinal cord, brainstem. Oh yeah, here you go. Ascending sensory pathways in the spinal cord, right? Which is your dorsal column and your spinal thalamic tract. And those are your ascending pathways. So if I damage my spinal cord in the back part or in the lateral spinal thalamic part, then I'm going to have a sensory problem. And that's called, localizing signs when we do it in neurology. When I make you do certain tests and make you do certain things, and with different body parts, I can start figuring out what you can sense and what you can't, and which cranial nerves work, which don't. And that's why one of the things we do, especially with your eyes, is I want to see if your pupils are equal and reactive to light, which is Perla. And I also want to see, you know, when they do that up and down, like sign of the cross thing with your eyes, and then they want to see if your eyes can move up and down, left and right, and diagonally. We want to see that kind of thing too. And you can see here, there is a specific tract. There's a specific set of a bunch of nerves that deal with your ascending sensory pathway to your brain. Vision, and again, they have to move together because they have to compensate for each other. And this is vestibular ocular reflex. There's also the Edinger-Westphal. Just know, for my purposes, is that the eyes have to move together. And we already know the main reason is that because of the blind spot, your optic disc. And also, you want to be able to see depth of field as well. Your eyeball is connected and they cross in something called your optic chiasm. So you have your optic nerve, crosses in your optic chiasm, right? So you could see there's different parts of your field of vision that, and you could see they're overlapping, so that if one part gets messed up, the other one can make up for it. And you can see, where does it all get evaluated is in the cortical part of your brain, or your cortex, which is the top part. This is called your homunculus, or your sensory, right? And you could see in that part of your cortex of your brain, there's certain parts that are exaggerated because why? They have way more sensors. So you could see the most sensitive are your fingers, it goes, and your lips and your tongue here. And that thing that they were talking about, if you've ever heard that, oh, you actually view things upside down. And again, it's just that the way how your brain organizes things. So it takes the quadrants of the different fields, and then it puts it together in your brain. So your eyes don't really see anything. They're like a camera. They take whatever visual data and then they send it to the brain for processing. And that's why You have a nearsightedness, farsightedness because of retinal disparity, because things don't fall quite on the fovea centralis. And by things, I mean by light, okay? Now, this is also part of your visual stream. That's why it's very, and you can see whoever built us perfect. They put all the really important stuff like visual in the back. But the problem is, if you have a lot of damage here, here in the back part, let's say I got hit in the back of the head with a baseball bat. In 6th grade, I played ball since I was in, I don't know, 3rd grade, all the way up to college. And I played catcher, and stupid batter took a check swing and took an extra swing and hit me in the back of the head. All I know is when I came to, I couldn't see for a little bit, and it totally freaked me out. I think I was like 5th, 6th grade, something like that. That's all right. I have a whole history of a bunch of head trauma, and I'm fine, says me. I think. And descending pathways. You can see them here, and that's your corticospinal tract, and your major descending pathways. They cross in your spinal cord, and that's called your decussation of fibers. That's the reason why when you get a stroke on the right side of your brain, of your cortex on the right side of your brain, here's your cortex part of your brain, and it affects your corticospinal tract. It'll affect your motor, and it will affect the opposite side. Okay? And it's because of the decussation of fibers. That's what it's called. What's a reflex? Where's the picture of a reflex? Well, here's a picture of a reflex. Now, a reflex, like this knee jerk, and I'll have this thing that I'm, all these things that I'm compiling, I will have it in a nice Microsoft Word for you guys. Everyone has had this, right? Where the doctor or the nurse hits you on the knee and you kick your knee out. Well, this is to test 3 things: the muscles and the tendon, the nerve, both sensory and motor, and your spinal cord. Reflex has nothing to do with your brain. The reflex is a protective function. Okay. How many of you here burned yourself, maybe making some French fries? Did it just the other day. And you pull your hand away from the fire, right? Or the oil. You didn't feel it, did you? You felt it afterward, after you pulled your hand away. Yes? Right? You pull your hand away, then you feel the pain. And that's part of your reflex. Reflexes are created in your body to protect you. So one way we could test it is this. So you have a sensory. It's called your stretch receptor. It senses that your patellar tendon is stretched out. So what does it do? It sends a sensory, right, to your spinal cord, to an interneuron in your spinal cord, and then it says, oh, it's stretching, therefore I got to move my leg. Then it sends a motor back, and then you do what? You extend your knee. You extend your foot. That all happens, and then that all happens automatically because just like the example that I made regarding that hot oil falling on your hand, your body will want to react with, it would take too long to go all the way up to your brain and go, oh my God, my hand, it hurts. There's hot oil on it, and to pull away from it. would take too long. So we have built-in reflexes. Another classic reflex is a gag reflex. What if I put too much food in my mouth? What if I put something nasty in my mouth that tastes disgusting? I'm going to gag it up. I'm going to, and you're just going to start choking it up. Your brain barely understands that something disgusting is in your mouth, but your body's already trying to throw it up, right? Another reflex is coughing. If I blew noxious fumes like smoke in your face, you don't have to think about it. You sense it, right? Sensory. Then it goes to your interneuron. Then it goes to your motor neuron. And then what happens? You cough. So a reflex, those are the parts of the reflex. You have your receptor, sensory neuron, interneuron, motor neuron, right? Because those are the parts of a reflex. And it goes, and then it tells the rest of your brain through their spinal cord, everything that goes down, but after the fact. And it's done for a protective function in your body. And it's done also for a diagnostic protection, not diagnostic protection, but we also use this in neurology and in internal medicine as a diagnostic tool to check out, hey, is there something wrong with the tendon, something wrong with the muscle, something wrong with the nervous system, something wrong with the spinal cord? Because if this person doesn't kick their foot out, then now I have to start investigating all of these parts. Okay, and that is reflex. 1, 2, 3, 4, 5, 6. How many people do I have? 1, 2, 3, 4. Oh, I'm missing somebody. I have Miss Washington. I have. Oh, Miss Jones is twice. That's why. Okay. And okay. I can't read. Okay. All right. So I got everybody. Now let's see if we are done. Did we go through all the special senses? Let's see. Eye, ear, tongue, taste, nose, and smell. We're all good? We're done. So next week, when you come into lab, I'll have a quiz ready for you guys, and it'll be on this. And I'm gonna post a quiz for you guys to take momentarily. In the next 15 minutes, I'll give you guys a chance to look at last week's stuff. So what was last week's stuff? Week 6. And you guys could, instead of posting it, where can we post it? Post it on task 7. Right here. And if those of you already done a task 7, discussion 7, because some of you are a little bit ahead of the game, good job. I'll just tack that on extra credit. And remember, I'm gonna take out these tasks, discussions, and lessons for the next 3 weeks, so that you can now focus on these quizzes, which will be a nice practice for your final exam. And the topic from last week was skeletal. So I'll have a nice 10-item skeletal quiz in the next couple of minutes, and I'll put it in announcements, and then you could answer it in task 7. Okay, and then I'll just adjust percentages. All right, does anyone have any questions?
No, Professor.
All right, if you guys are good, hope to see how many of you? 1, 2, 3, 4, 5. I hope to see 5 quizzes probably in the next 30 minutes or so. I'll give you like 15 minutes. All right.
No
All
problem.
right. Kindly log off so I can go do this stuff, and I'll see you guys I'll see you guys next week on campus. And again, if you can't make it, I need to know. We need a formal email so I know know how to prepare. All right, everybody, look out for the quiz in announcements in the next 5 minutes. All right, see you soon.